This is Mon Health Talk, a weekly program focusing on the dedicated physicians, nurses, and staff at Mon Health, the region's premier community hospital system. People with skillful hands and bright minds using state-of-the-art technology. We don't just practice medicine, we care for people like family. That's why at Mon Health you can feel the difference. Once again, welcome to this edition of Mon Health Talk.
Good morning, welcome into the program, and final day of February, final day of Heart Month, and we'll continue discussing the heart. Our guest this morning, vascular surgeon, going to try my best, Dr. Mohit Srivastava, joining us on the program. Am I close?
Oh, no, that was actually perfect. Yeah.
Not bad, huh?
Okay. No, not at all.
Well, I will try to say it as few times as possible so I don't mess it up that much. But, hey, thanks for taking some time with us. We're going to talk about vascular advances this morning coming up on the show. But before we get into that, let's learn a little bit more about you. Give us a little of your background, education, training, and how you ended up with Mon Health.
Yeah. So I really, first off, kind of appreciate you for having us on the show here. I'm here with Laurette, my expert practitioner, and I'll turn over to her in a second, and she'll be able to introduce herself as well. But no, I'm Mohit, and I'm one of the vascular surgeons here at Mon General. I actually grew up not far from West Virginia in Columbus, Ohio, and I spent obviously most of my younger years there, and then when I was moving on to college and med school, I did most of that or all of that in the northeast part of Ohio, and then after that was done, I did my general surgery residency, which is about 5 years that we all kind of go through. I did that in Philadelphia, and then I was obviously interested in vascular surgery as a specialty, and so when I was done with my residency, I did a 2-year fellowship in Charleston, West Virginia, and that was where I came to learn and love West Virginia, and it was meant to be a 2-year fellowship, but we loved West Virginia so much we stayed here, and I worked in Charleston with a group I stayed on after my 2-year fellowship for about 10 years, and then my wife actually was lucky enough to get into the school here at WVU, so we moved here to Morgantown, and I took obviously the job here at Mon General a few years back, and I've been here for a few years now.
Was vascular surgery something you set out to do from the beginning, or was that an interest you developed through the course of your training?
So kind of always interested in med school and everything, but probably through the 5 years of residency. It's why, it's at least it's weird to call it the older days now, but I guess it's the older days. All of us kind of went through those 5 years where we got exposed to all the different types of surgical specialties, and I really enjoyed vascular, and then when it came time that was over, I just kind of chose to pursue that as a primary specialty.
And you mentioned also joining you this morning, Laurette Flannery, MP, with Mon Health Heart and Vascular Center. Good morning, Laurette.
Good morning. Glad to be here with you today.
Same kind of question to you. Give us a little bit about your background.
Well, I spent the first part of my career in Philadelphia, PA, and I actually started out in physical therapy, and I worked with some of the sports teams there. However, I did get involved in some wound care programs, and I was just completely entranced by the wound care and the healing process. That led me down the path to the nursing career that I have today, obtaining my BSN and my MSN, my NP, and then finally my doctorate from Millersville University in Pennsylvania. I desire to know more about the body and pathophysiology and what can be done to help improve the quality of life in those suffering from wounds led me to the world of vascular.
And how did you get connected with the doctor there?
So I relocated to West Virginia to be near some family members, and I just started looking and searching, and one day somebody from Mon Health just answered the phone, one of the recruiters, and we spoke, and she said, wow, we have this great guy, Dr. Mohit Srivastava here, and we met, and it turns out we may have crossed paths, who knows, we've been to Philadelphia together, and so here we are today sharing this practice.
And we're going to talk about vascular advances this morning, so let's jump in and talk about a few procedures. Dr. Mohit, what is TCAR, and when would a patient need this?
Yeah, so it's, a lot of it has to do with, obviously with us So sorry there. Yeah, I thought I got something there. Sorry about that. The TCAR is one of the newer procedures we have out nowadays. It's one of the newer advancements we have in carotid disease, carotid artery disease, and carotid artery disease for everybody who's listening. It's a buildup of hardening and blockage in the artery in the neck, and one of the most devastating things that it can do, unfortunately, is it can break loose and it can travel to the brain. And, when it does that, it can have the devastating consequence of giving you a stroke, a mini stroke or a full-blown stroke. And so what I would tell you is that, to always look out for those things. But as we get older, we can get these hardening and blockages everywhere, the neck arteries, the leg arteries, the heart arteries, everything. And previously, one of the only options we had was a surgery, which is actually a very good operation, something every day. And I'm so sorry. Are you still there?
Yep, we're still here.
Good. I do apologize. Sometimes when my pager goes off like that, I hate it, but I do apologize. But,
no problem.
Yeah. The idea is that you always want to be vigilant, and the options used to be, a pretty standard operation that we did, that we still do, and it's a very good option, but it does involve an operation, which is about 3 to 4 hours, and a lot of times we do have to go under general anesthesia, and it can involve a rather lengthy dissection in the neck and a relatively bigger operation. Nowadays we have an option where we can actually go through the inside of the artery and we can put a stent that kind of traps that material to the wall of the artery and sort of expands it a little bit, and that can allow blood flow to be restored and at the same time prevent that debris from going anywhere. And we used to have to do it, or we used to only be able to do a stent going the old-fashioned way, through an artery in the arm, an artery in the groin, like we do for a heart catheterization. But now we can do this through a very small cut in the neck, and it has one very significant benefit over either of the other two ways of doing it. And it has this concept, we call it a reversal of blood flow. Basically, the blood flow that normally goes up to the brain now flips and actually goes downward. And what that means is that when you're going in on the inside of the artery and opening everything up, you don't want that debris going anywhere while you do that. And so in the end, what I would do is, for lack of better words, or what I would normally do with this procedure is we would have it hooked to an apparatus that would allow that blood flow to temporarily flip. So when we open the artery with a balloon or a stent, the only place that any debris that can possibly go is actually outside and out of the artery rather than up to the brain. And it's all still done through a needle stick in the artery, just a much smaller cut above the neck. And what we found is the rates of having anything happen while we do this are the lowest of any type of intervention that we do for this artery in the neck. And most folks, they tolerate it very, very well because it's just a small incision. It's only sore for a couple days, and then it's done. And usually they do very well. Typically we stay overnight and we head home the next day. But it's a really great new option for folks, and it does have its requirements, things that we look at, but at the same time, it's also the kind of thing that it offers a minimally invasive way of fixing a blockage in the artery without patients having to go through too much. And so a lot of our folks who are a little bit older, who maybe can't necessarily tolerate the traditional way of doing it, they have this now as an option.
Our guest this morning, Dr. Mohit Srivastava and Laurette Flannery, a vascular surgeon and MP, Mon Health Heart and Vascular Center. We'll continue the conversation talking vascular advances. As soon as we squeeze in this break, you're listening to Mon Health Talk on WAJR.
Now back to Mon Health Talk, a discussion of the issues, people, and procedures in healthcare today. If you have a question for one of our healthcare guests, call now at 304-296-0041.
Dr. Mohit Srivastava and Laurette Flannery is our guest this morning. Grammar does elude me sometimes. Dr. Srivastava, a vascular surgeon. Laurette Flannery, MP, Mon Health Heart and Vascular Center. Laurette, where does your role come into play in these procedures?
So my role is very much supportive to Dr. Srivastava. I help plan all of the surgical procedures. I put all the orders in for all the patients, make sure that they are pre-educated. Nurse practitioners are very focused on education. We make sure that the patients understand their medication regimen, what the procedure will be, and what their aftercare will be. I also am a provider at the wound care center, so should we have any residual wound care needs for the patients, they can join me at the wound care center 2 days a week, and we can be more consistently involved in their wound care.
What are some of the common questions patients have when they're getting ready for a procedure, like the one we just talked about in the previous segment, the TCAR procedure? What are some of the common questions they have for you?
The most common questions are the length of the hospital stay, how long they'll be hospitalized. Other common questions are what types of things will they not be able to do after surgery, such as driving, lifting, bending. Many of these surgeries involve the patient not being able to drive for several weeks, also not being able to lift more than 5 pounds, bend at the waist, and squat. So we, educate them in advance and then provide them with thorough written education on their way out the door.
I would venture to guess, well, any procedure I would imagine comes with some level of apprehension, but if we're talking about anything regarding the heart, I would guess the patients often are very anxious, very apprehensive. How do you kind of put them at ease going into some of these procedures?
I would say that any patient going into any procedure, particularly with our COVID pandemic, they're all very nervous about being hospitalized. We assure our patients that we follow the utmost procedures for infection control. We have private rooms for our patients, and we provide them with one-on-one care. And actually, I would say that 100% of my patients going into their procedure are thoroughly aware, fully educated, and I think that's what makes them at ease the most.
We're talking about vascular advances this morning. Dr. Mohit Srivastava and Laurette Flannery joining us. And Dr. Srivastava, tell me about abdominal aortic aneurysm, or AAA. What is that, and what are the risk factors?
Well, an abdominal aortic aneurysm is basically, and there's a couple different types, and there's a variety of different reasons. And what I always tell people is we've had kind of the privilege over the last half a century of being able to study these aneurysms and look at everything from the way of infection, immunity, antibodies, diet and exercise, and even genetics, which actually plays a rather big role in it. It has about what we call a 15 to 20% genetic preponderance in families. And so we always tell people, in the end, what we really want to be able to do is make sure that whoever has an aneurysm, we absolutely take care of them and everything that they need, but we also educate them that any first-degree relatives that are still alive, above the ages of 55 to 60, mom, dad, brothers, sisters, or children, they are all checked off to get an ultrasound as well, because 1 in 5 of them will also likely have an aneurysm. But it ends up being a weakening in the wall of the main pipe that the heart pumps out all of its blood into. Now, I always liken it to a rubber hose that you buy on the first day where the fabric is strong. You can kind of crank up the water all the way, and that hose will be nice and tight and exactly what you want it to be, without any leaking, without any weakness, without anything. But 20 years later, as the fabric withers away, when you crank up the water, it can start to bulge out. It can start to kind of torque and bend on itself a little bit. So the idea is always the same, that in the end, what we're looking at is that you have a weakening in the wall of that main pipe. And it typically happens in the belly, and it typically sits somewhere between the kidney arteries and the leg arteries in that main pipe. And the benefit nowadays is that when it comes time to treat those, and ideally they have to reach a certain size, they ideally have to reach a certain size and or be growing at a rapid rate for us to typically need to treat them. But the good news is nowadays 85 to 90% of them can all be treated through a very minimally invasive way, much like the TCAR.
Are there steps you can take yourself to prevent complications from that down the road? I assume diet and exercise would be two big things.
Yeah, we say that the highest risk factors for just in the general population, family history aside, are actually, we see it more in men than we do in women, typically over the age of 60 to 65, and usually if they have high blood pressure or they smoke. So one of the biggest things for anybody that we see with an aneurysm, because as you can imagine, majority of the ones that we actually meet for the first time aren't at the size that we need to treat them, and so we follow them over time, to see if they're growing, if they ever grow to that point that we need to treat them so we can catch them before anything bad happens. Bad, obviously, being the most serious thing, which is that the aneurysm bursts, but at the same time we try to catch all of them before then. The idea is, though, if we're following them, or even if they're already at a point where we fix them, we always educate them on not just diet and exercise, but stopping smoking and keeping your blood pressure under control. Those are two of the bigger things you can do over time.
We often follow different types of research and studies, and the United States Preventative Services Task Force team recommends that men 65 to 75 have at least a one-time screening, especially if they've smoked more than 100 cigarettes in their lifetime.
How often do you have to screen? If you detect that aneurysm, how often do you go back to screen it, to check on it, and like you said, catch something before it becomes something?
So that's a great question, and we have kind of an algorithm we follow. If it's, there's basically the size where it's big enough we have to fix. Then there's kind of a smaller size, and then there's sort of an in-between size. And so the idea is much like anything else that grows in size. You have the early stages of it, then you have kind of the intermediate stages, then you have the stage where it's time to really fix it. And so if it's in the smaller stages, we typically follow it about once a year with an ultrasound. If it's in the intermediate stages, a lot of times we'll do it every 6 months or so just to catch it, hopefully, when it gets to that point. And then obviously if it's already at a point where it's time to treat, then we go ahead and we just fix it then. And if we do fix it, then typically that first year we'll check it with a CAT scan a few times that year just to make sure the stents and everything are all in place. And then after that, typically just once a year with an ultrasound.
We'll wrap up our conversation with Dr. Mohit Srivastava, vascular surgeon, and Laurette Flannery, MP, Mon Health Heart and Vascular Center. We're back in a moment on Mon Health Talk on WAJR.
This is Mon Health Talk, providing a window into the Mon Health system and the dedicated healthcare providers who work there. If you'd like to comment or ask a question, please call 304-296-0041.
Less than a minute left, actually about 20 seconds. Dr. Srivastava, where can we get more information?
So, what we can do, and for anybody, we have obviously our office here at Mon General Hospital and the hospital itself, and then we also have, we're able to, via our website, for anybody looking for anything vascular, whether it's a question or, myself or Laurette. And Laurette also works at the wound center that we have here in